The next few slides, we're going to talk about providing MAC, like pre-op assessment and complications, etc. So when it comes to pre-op assessment, the pre-procedure assessment and evaluation is an essential requirement of MAC. It's a requirement. You have to do it. It should be as comprehensive as what you do before any general or regional anesthetic. For MAC, in addition to the normal pre-op you do, you should also evaluate the patient for their ability to stay motionless or be cooperative during the procedure. The ability to remain still can be very important for certain MAC procedure, both psychological, like claustrophobia, and physical, like somebody who's a heavy smoker who always coughs, and orthopnea. These issues could serve as a barrier to your being able to provide a successful MAC. Patients should also have intact cognition. Continuous verbal communication between patient and you during MAC is necessary for reassurance, patient safety, and monitoring the level of sedation. So, if you're doing a cataract on somebody with severe dementia, be very careful giving a MAC if the patient is not cooperative and can be easily frightened, move, cough, run away. That can cause some major problems. The same level of patient monitoring is required during a MAC compared to general anesthesia. Monitoring should include, most importantly, communication and observation. So, response to verbal stimulation, observation of rate, depth, and pattern of respiration, feeling the pulse if the blood pressure's cuff is misbehaving, assessment of peripheral perfusion by extremity temperature, capillary refill, and diaphoresis, pallor, shivering, cyanosis, and acute changes in neurologic status. And actually, in the last few years, I've been kind of more clinically focused on perfusion index. And if any of you guys are interested in designing a research project, I have some ideas that I want to work on. And you're still early in your career, so we still have some time to go through the IRB and actually do the procedure. Also, auscultation or precordial stethoscope. We do have them. If you haven't used it, I'll be happy to show how to use it. It's rather surprising how simple it is. You need pulse ox, capnography, ECG, non-invasive blood pressure at least every 5 minutes. This is one of my personal pet peeves. So, when you transfer the patient at the end of the case from the OR table to the patient's bed, there's a PACU delay of 15 minutes. You're not measuring blood pressure. That's a violation. That's a rule that we have to do. It's not an advisory. It's not a guideline. We have to do it. So, temperature guidelines are the same as general anesthesia. In terms of BIS monitor, SedLine, processed EEG is not mandatory, but you can do it. It's actually quite interesting when you put a SedLine on somebody under sedation. It kind of tells you how often the patients are in isoelectric or burst suppression. It's kind of shocking sometimes. And most importantly, the BIS monitor is preparedness to recognize and treat local anesthetic toxicity. Now, this is something that we have traditionally haven't been very good at. We do our nerve block, wait a couple of minutes, document, and then we're gone. High risk of nerve toxicity, the last persist for definitely the first 30 minutes and remains for up to 2 hours. So you can't just do a nerve block and send the patient home an hour later. You have to monitor them. We got to make sure the absorption is not dangerous. During MAC, the actual anesthesia or loss of pain is provided by the local anesthetic that the surgeon injects. Your job is to provide sedation, amnesia, anxiolysis, and analgesia in addition if needed. You can use barbiturate, benzos, propofol, etomidate, ketamine, dexmedetomidine, methotrexate, whatever you want. And you can give them with intermittent boluses, variable rate infusions, target controlled infusions if you go to Europe. and patient-controlled sedation, which we're not using in an institution, but there are propofol or remifentanil PCA pumps that have been used. To avoid excessive level of sedation, you should give the drugs and titrate them in small increments, or my favorite is use an infusion and adjust the rate in response to the level of nausea stimulation. Provision of a quality MAC should lead to rapid recovery without side effect. And again, I want to repeat this. Provision of a quality MAC should lead to rapid recovery without side effect. So that's our goal. Side effects are not acceptable. I'm sure there's some questions about that. Well, we can talk about it at some point later. According to the ASA closed claim database, the risk of injury during MAC is similar to GA or regional. Both MAC and general claims had similar incidence of permanent brain damage and death, and inadequate oxygenation and ventilation, usually from heavy sedation with propofol, opioids, or benzos, were the most common respiratory complication in MAC claims. And nearly half of these claims involved operation on the head and neck. So these are, higher risk surgeries in terms of complication because we have restricted access to the patient's airway. Now, some other complications during MAC may be eye injury secondary to movement during ophthalmologic surgery. This is a big deal. You have to think about it every time you do cataract or anything else, any eye procedures under sedation. Fires, burns, local anesthetic toxicity. There's also possibility of awareness and recall. And this is an important thing to talk to patients if you think you're not going to keep the patient too deep. You tell them, my job, you're going to remember this, but my job is to make sure this is not an unpleasant experience. Any MAC cases may require conversion to general anesthesia. So if somebody has a contraindication to general anesthesia, you cannot provide MAC. Emergency cases, different story. Something we have to do, different story. But elective cases for MAC with contraindication should be canceled. And factors that can contribute to complications during MAC are lack of attention to monitors, disabling the monitor alarms, delayed recognition of cardiopulmonary events, and improper resuscitation. So again, same factors compared to general anesthesia.